Good evening, ladies and gentlemen. A very, very warm welcome and a belated happy Diwali and a happy new year to all of us. Welcome to Secrets of Neurology. It's a knowledge feast for all neurologists. And I can very humbly say that this probably is one of the longest running academic webinar, may not be just in India, but probably in good part of the world. Today is episode 63rd, which is fifth year plus. And what an honor to have the presenters from Bombay Hospital, and I can very vividly see Dr. Satish Khandilkar on the screen as well. Today's topic is very interesting. Caught before the damage, the story of a reversible genetic disease. And in today's presentation, you would see a great synergy between various departments, including Department of Genetics. A warm welcome to our program directors. Their grit, determination, perseverance, and ability to strive and connect the chord with all the neurologists have taken us so far. Professor Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan. And on the same breath, I would also like to welcome Dr. Satish Khandilkar sir, Dr. Varsha Patil, Dr. Jharna Mahajan Bhanushali, Dr. Nadir Edi Varucha, Dr. Shruti Bajaj, and Dr. Shamiksha Khade. A bigger introduction follows from our program directors. An honor and a privilege to introduce a person who needs no introduction. He's always supported us, guided us, and that's why this academic neurological feast, Professor Dr. Sudhir Shah. Professor and HOD at prestigious Srimati NHL MMC SBP IMSR Ahmedabad. Dr. Sudhir Shah sir is also Director of Neuroscience at prestigious Sterling Hospital, Ahmedabad. Many awards and contribution to the field of neurology, author of 6 books on neurology. Because of his immense contribution to humanity, human beings, research work, and clinical contribution to neurology, Government of India conferred prestigious Padam Shri to him. And very recently, Professor Dr. Sudhir Shah sir was also awarded with Bharat Gaurav Award at Senate of France on 5th of June 2024, one of the highest international award for an Indian. Dr. Sudhir Shah sir is also recipient of prestigious B.C. Roy Award, many interests, including stroke, neurodegenerative disease, and epilepsy, to our program director's contribution. A warm welcome to our second director. We know, and sir also needs no introduction, Professor Dr. Lakshmi Narasimhan Ranganathan sir. After building and flourishing an institute such as Madras Medical College, today sir is also Director and Professor Department of Neurology at Sri Ramchandra Institute of Higher Education and Research, Chennai. Many awards and accolades, and both our program directors have always guided us to be very brief, so I'll do the same. Paltusi Advisor from AN, A.V. Baker's Award for Global Best Teacher from American Academy of Neurology, Best Paper Award from American Academy of Neurology. And what we fondly know him is his contribution to neurology in India. 3 terms executive member, Indian Academy of Neurology, CME convener at Indian Academy of Neurology, and successfully organized 7 consecutive clinical neuroscience program for all India DM postgraduate students. So contribution to the young budding neurologist has also been immense by both our program directors. May I request Dr. Sudhir Shah sir, I know sir you are traveling, but we would like to hear you, and we would also like to hear Dr. Lakshmi Narasimhan sir.
Thank you. Thank you, Dr. Manoj, for your kind words of introduction. At the outset, let me first welcome all our colleagues across India and abroad who are on net today attending this webinar. First of all, Happy New Year to all of you. May God bless us all with health, happiness, peace, prosperity, and joy. I want to thank all the delegates who have been so supportive all these years. We are now on 63rd episode, which is according to as what Manoj said, is one of the highest achievements. And I think without your continuous inspiration and interest, we would have not gone this long way. Also, thanks to all the different hospitals and institutions who have given cases and presented marvelous series of knowledge sharing, and thanks to all of them. Today, we have with us one of the most, I would say, premier institute of India, that is Bombay Hospital of Medical. Satish Kalilkar is the Dean and HOD of Neuroscience. Hello. So, I welcome you all, Professor Barucha, Dr. Varsha, Dr. Bajaj, and all team. And I want to hand over to my able colleague, Dr. Lakshmi Narasimhan, our incoming president of IAN, who has been the pivotal force in running this show. So, thanks to Dr. Lakshmi. And last but not least, I want to thank Mr. Chadda and team of Celestial Division of INTAS for supporting this fantastic academic activity all throughout by providing networking and logistics. Thank you. Dr. Lakshmi, kindly take over and
Yes, sir. Yes, sir. Thank you, sir.
presenting the case, a wonderful case from Bombay Hospital.
Thank you, sir. Hello. Shweta? Yeah. I take the pleasure of introducing Dr. Shamisha Khare from Senior Resident in the Department of Neurology, Bombay Hospital, Mumbai. Prizes for the presentation of Indian Physician Congress 2021 and Swastik 2019 and BNA 2025. 9 publications to her credit. Next, I take the immense pleasure in introducing Dr. Jarna Mahajan, Bhanushali, Associate Consultant, Department of Neurology, Bombay Hospital, Mumbai. DM Neurology Gold Medalist, MD Medicine, MBBS. General Neurology and Neuromuscular is an interest. 6 publications to her credit. First rank in DM Neurology. Prizes for the best platform presentations like INCON and the Bombay Neurology Associations. Prizes in various quiz competitions. Next, Dr. Varsha Patil, Consultant, Department of Neurology, Bombay Hospital, Mumbai. 23 research articles, 15 book chapters, section editor, Neurology, 5 minutes consult, South Asian edition. Faculty at various national conferences, prize for best platform in interims and poster presentations. Joint organizing secretary in the midterm conference of NAMS. Areas of specialization, autoimmune neurology and pediatric neurology, epilepsy. Next, I have Dr. Shruti Bajaj, Director and Consultant, Clinical Genetics, Purple Gene Clinic, the Purple Gene Clinic, Mumbai, SRCC Children's Hospital, Mumbai, Saifi Hospital, Mumbai, Bombay Hospital and Institute of Medical Sciences, Mumbai, Neurogenetics, Skeletal Dysplasia and Dysmorphology, 39 publications in 7 chapters in various textbooks, 9 first prizes, 3 second prizes, podium poster presentation, national and international conferences, winner of the travel scholarship to Barcelona for Masters in Neurometabolism and Cell Biology for consecutive years in 2022 and 2023, founder, secretary of PEHEL, a support group for individuals with Down syndrome. Welcome to you. Welcome you, madam, for this wonderful academic feast.
Thank you. Thank you so much, sir.
Professor Nadir Edi Barucha, one of the doyens of neurology. We are extremely honored by your presence, sir. Chief of Department of Neuroepidemiology, Bombay Hospital. Neurologist, Bombay Hospital. Chief, Department of Neuroepidemiology, Bombay Hospital. Former Professor and Head of Department of Neurology, Bombay Hospital, Institute of Medical Sciences. Honorary Neurophysicians to the Honorable Governor of Maharashtra. 100 peer-reviewed publications, chapters, including 4 chapters in Bradley and Deroff, Fenical, Marsden, and Neurology in Clinical Practice in 1991. Publications have been cited over 2,500 times. Clinical General Neurology, Neuroepidemiology and Rural Healthcare. Achievements and Awards. Baldev Singh Oration, National Academy of Medical Sciences. A.D. Siegel Oration, Indian Epilepsy Association. Wockhardt Medical Excellence Award, Harvard Medical International. Chairman Commission of Epidemiology and Prognosis, ILAE. Member Commission on Tropical Diseases, ILAE. Advisory Committee member of WFN Research Group in Neuroepidemiology 1998 to 2001. Senior Fellow of American Academy of Neurology. Overseas member of ABN UK. Overseas member of American Academy of Neurology in Australia. Welcome you, sir, for this academic endeavor. Next, I have the next slide, please. And Professor Satish Kadilkar, Dean, Bombay Hospital, Professor and HOD, Department of Neurology. He is a mentor to hundreds of neurologists across the country. Every neurologist in the country would like to emulate him on all aspects. I always look at him as a whole faceted neurologist. And his kindness to patients, his empathy towards his colleagues, his academic caliber, and his cool and calm approach in every. You can trust him for any crisis in your life. For all the youngsters, I'm telling this. Any crisis, whether it is academic or personal, you can always approach him. He's a very, very great person whom I love to interact with. I welcome you, sir. And designations: is the Dean and Head of the Department of Neurology, Bombay Hospital Institute of Medical Sciences, Mumbai, past President of Indian Academy of Neurology, ex-Secretary of Asian Oceanian Biology Center, Neurology and Neuromuscular Disease, over 200 publications. And I would say is a father figure in the myology in the country. And over to you, sir. Kindly take over the proceedings. Thank you.
Thank you so much, Lakshmi and Sudhir. I think it's so nice to see both of you and also to be here for this program. Today, what we have for you is a very interesting case which has many illustrating aspects to it. So without further ado, let us begin. And let me request first Shamisha to start her presentation. Shamisha, you want to share your slides?
Yes, sir. Is it visible, sir?
Yeah, visible and audible. Do go ahead.
Yes, sir. Good evening, everyone. I'm Dr. Shamisha Khade, Senior Resident in Department of Neurology at Bombay Hospital. So today we'll be discussing one of the interesting cases that we had come across recently. So let me begin with the history of the case. Our patient was a 28-year-old female who had come with history of walking difficulty and difficulty in getting up from sitting position from last 1.5 years. She also noticed some difficulty in chewing while having food since past 1 year. She was apparently all right a year and a half back when she started having difficulty in getting up from sitting position and climbing stairs. She also noticed some difficulty in walking. However, she also noticed that there were some fluctuations. There were some good days and some bad days. On good days, she was able to do all her day-to-day activities comfortably on her own, whereas on bad days, she would get so much worse that she was unable to even walk around in the house or even go to the washroom on her own without support. She also noticed that there was some variation in it in the form of the weakness getting worse in summers and getting better in monsoons. After 5 to 6 months, she also noticed that she had some difficulty in chewing, especially while having solid food, when she was trying to bite onto the food for a prolonged time. Other than that, she is able to carry out all her activities with her upper limbs. She was able to turn in bed comfortably. Her vision was good with no diplopia. Speech and swallowing was preserved. There were no sensory symptoms, bowel bladder disturbances, or imbalance or incoordination. On further history, her birth history was normal. She was born of a non-consanguineous marriage with antenatal history being unremarkable. She was born of a full-term normal delivery with average birth weight, and she had attained all her developmental milestones on time. On family history, we found that there were similar complaints in her brother as well. The brother was 37 years old at the time when she had presented to us. However, his symptoms had begun at the age of 21 years. The brother also had history of passing the National Defense Academy exam. So in the form of he had undergone strenuous physical activity at that time, after which he started experiencing weakness in bilateral lower limbs proximally, also fatigue on walking even for 50 meters. His documents reveal that he had a race CK total levels of 1151, which was documented in 2008, and his muscle biopsy was normal. He had history of taking some Ayurvedic medications for the same, details of which were unknown, but now he was better since last 4 to 5 years. So on history, we got 3 major anchors. First was proximal weakness, second was fluctuations, and third was a positive family history. So on basis of proximal weakness, we could think about the diagnosis being at the level of muscle, that is myopathies, or at the level of neuromuscular junctions, so in the form of congenital myasthenic syndromes or myasthenia gravis, autoimmune myasthenia gravis. And third, anterior horn cell, some sort of spinal muscular atrophy. Now, adding fluctuations to the picture, we could bring down the diagnosis to either neuromuscular junction disorders or myopathies, especially the metabolic myopathies. And third, periodic paralysis, either hyperkalemic or hypokalemic periodic paralysis or thyrotoxic paralysis. And now adding family history to the picture, the localization went to neuromuscular junction disorders, being congenital myasthenic syndrome or myopathy. Now let us move on to examination. On examination, she was averagely built with a weight of 57 kgs and height of 158 centimeters. Her higher mental functions, cranial nerve examination and sensory examination was normal. On motor examination, she had a normal tone and nutrition. And on power testing, she had neck flexion as well as extension weakness. Her trunk was also weak, and her MRC power at the hip was 4/5. She had a waddling type of gait with Gowers sign being positive, and also showed fatigability in her during her examination, so much so that with repeated movements there was a drop in the MRC grade of power as well. Her deep tendon reflexes were preserved with the plantars being flexor. So here are a few clinical videos of the patient. I would like to play them. So in the first video, we can see that she's having some difficulty in getting up from seated position. She has to rest her hands on the thighs or even hold on to support to get up from sitting position. The second video shows that is a video of her walking. As we can see, there is a waddle when she walks. So in the next video, we can see that she has significant neck flexion weakness, so much so that she's not able to lift her head up against resistance applied. And there's another video of her trying to raise her hands up above her shoulders. As we can see, in the beginning, she is able to do it comfortably, but with repeated movements, we can see that she is struggling to lift her hands up above her shoulders, suggestive of proximal upper limb weakness as well, showing fatigability. So I would like to summarize the case. My patient the patient has come with a third decade onset, insidious onset, gradually progressive, bilateral, symmetrical, proximal upper limb plus lower limb weakness with fatigability, with no sensory symptoms, no bowel bladder or cranial nerve involvement. So with this, I would like to move on to the provisional diagnosis now at the end of examination. So now after examination, we could narrow it down to 3. First is the neuromuscular junction disorders, being congenital myasthenic syndrome. Second being limb girdle myopathy. And third being autoimmune myasthenia gravis. So then we moved on to investigate her.
Before
And
before
on
that,
investigations, we could see that her...
Shamisha, 1 minute. Dr. Varsha, you have any comments or questions at this
Yeah,
point?
so, before we go to the investigations, am I loud and clear? Shamisha, this is a clinical case. So you've
Yes.
given us some provisional diagnosis at the end of your history, and now you've given the diagnosis at the end of your examination. So what are
Yes,
your pros and cons, or for and against each of these diagnoses that you have? How will you, in your mind, now decide how will I investigate this patient?
So after history and examination, we've narrowed it down to congenital myasthenic syndromes, limb-girdle myopathies, and myasthenia gravis. Points in favor of congenital myasthenic syndrome is the age of onset, being the third decade, family history being positive, history of proximal upper limb, lower limb weakness with chewing difficulty, again suggestive of the neuromuscular involvement, and the fluctuations in the symptoms that she has. For limb girdle myopathies, the points in favor would be proximal upper limb and lower limb weak involvement, with a family history being positive. And points against it will be the fluctuations in the weakness that she has.
So at this juncture, Shamisha, I just want the audiences to give just one diagnosis that they want in the chat box. And then at the end of it, let's see if their diagnosis and our diagnosis tallies.
Yes, ma'am.
Go ahead with the investigation.
That's interesting. Do put your diagnosis, as Varsha says.
So now we move on to the investigations.
நீ சொல்லுடு நான் பேசுறேன் மெசேஜ் போடு நான் எனக்கு உடம்பு சரியில்லை மெசேஜ் போடு நான் வர சொல்லி
On investigations, routine investigations were first performed. Her hemogram was normal, ESR was normal, renal function tests were normal. On liver function profile, bilirubin was normal. However, her SGOT and SGPT levels were raised. Her LDH levels were also raised. And CPK total levels were 1718, which were then repeated after a week, and which was 3061. Her acetylcholinesterase receptor antibody were sent, which turned out to be negative. Then we went on with the electrodiagnostic studies. On electrodiagnostic studies, we found a primary muscle disease involving both upper limbs and lower limbs with small and short MUAPs. On repetitive nerve stimulation test, there was no decremental response which was found. So after this, we were again in a fix as to how to go about it. And that is when we sent a genetic test, that is whole exome sequencing. It was performed to evaluate for congenital myasthenic syndromes or limb girdle muscular dystrophies. And the analysis revealed 3 heterozygous variants of uncertain significance in the SINE-E2 gene, which is associated with Emery-Dreifuss muscular dystrophy type 5. However, the clinical phenotype did not really match with the genetic report that we found, as the patient's presentation was inconsistent with the typical features of Emery-Dreifuss muscular dystrophy. So there was clearly a discordance between the two. So then we again revisited her genetic report, and on revisiting that, hidden on the 3rd page of the genetics report, we found a heterozygous mutation in the ETFDH gene with a variant of uncertain significance again for glutaric acidemia type 2C. So this discordance between the genetic genotype and phenotype, along with this variant of uncertain significance that we found, prompted a multidisciplinary review, and hence a clinical geneticist was subsequently involved for further evaluation and interpretation of the genetic report. So after this, Dr. Shruti Bajaj ma'am was involved in the case, and
at this point, Dr. Shruti, do you want to make a couple of comments about how to read this report,
Yeah.
and then we go ahead?
Yeah. Sure. Samiksha, do you mind just skipping 2 slides behind?
yes, ma'am.
Yeah, so first of all, good evening. Thank you for this kind opportunity. I will come directly to the point of how do we analyze this. As you see, there are various, I'll try to get a laser pointer here. Okay, you can see that there's gene and variant, and then there's zygosity. What do you mean by zygosity? All of us carry two gene copies, two alleles for every gene, correct? Heterozygous means only one of the gene is mutated, the other gene copy looks okay. Now you may wonder that how come there are three heterozygous when there are two gene copies? How are we getting three variants? That's possible because these three variants could be distributed in various permutation and combinations, all three on one thread, two on one on the other. But as Samiksha rightly said, when we are faced with an uncertain significance, like in any clinical scenario, say you find an uncertain MRI finding, you as neurologist, I'm sure, would do topographic analysis. Is it matching the anatomy and stuff? So we as geneticists go back, look at not just the clinical picture, but also a lot of what we call as variant annotations. We look at the variant details, the computational tools. And so to cut a long story short, although the zygosity was matching with the mode of inheritance, for autosomal dominant disorders, we get heterozygous variants, but still because of multiple other reasons, this was discarded. And this is what happens. This is a little bit of caution to the colleagues that nowadays patients have accessibility to genetic test as OTC test over the counter, and they'll come to you with reports. Very often we are tempted to just look at the first page. But I think it's important to turn all the pages. Don't just get carried forward by the colors that they use, red hair, or if it's marked in green, it's not no. So we have to look beyond because what the bioinformatician is saying and what the clinician sees could be different. Next slide, please. I still remember the day when my counseling team was preparing. Next slide, please. And they came before I could enter the clinic. They were rushing, Madam, we have a treatable myopathy today coming to the clinic. And this was because we had studied this variant so thoroughly. You can see we have tools like Franklin, Warzone, ClinVar. These are various tools that we use along with being clinicians. It's a bit of a computational education that we put to apply. And we were very sure that come what may, this girl is definitely going to have glutaric acidemia type 2C. And then when we went back, all her features seemed to fall in place. Although you see the same villain over here, variant of uncertain significance. So this is just a word that every word that's written on the report is not the holy grail, and sometimes the truth may be deeper and may not appear very evident immediately. So this is just that variants of uncertain significance need to be dealt with a lot of depth and respect. I think that's about it, sir.
Yeah, lovely. So I think this report and the patient went to Dr. Bajaj and then came back. So Dr. Varsha, you want to take it further? Or Shamisha, you go ahead. Yeah,
So, maybe Shamisha could just say what we did now with the patient
right.
Yes, sir.
and what she wants to probably do next to get her better.
Yes, ma'am. So a metabolic profile was sent, and her urine organic acids showed mild elevation in 2-hydroxyglutaric acid, so which was consistent with the diagnosis of glutaric acidemia. Thus, we reached the final diagnosis of late onset glutaric acidemia type 2. She was then treated with oral riboflavin 400 milligrams per day and coenzyme Q 600 milligrams per day. And with this, after 4 weeks, when she had come to follow up, we saw that she had a dramatic response. So I would like to show some clinical videos of her when she had come to follow up with us after 4 weeks. So as we can see, now she is able to get up comfortably from sitting position. In the earlier video, she had severe difficulty in getting up. And this is another video of her trying to raise her hands above the shoulder. Even now, this she is able to do comfortably. And there was no fatigability which was seen in the post-treatment videos. Here is a video of her trying to climb stairs. And another video of her climbing down and then again climbing upstairs with no fatigability. So, thus, with the help of simple vitamin supplements like riboflavin and coenzyme Q, the patient got better in around 4 to 6 weeks.
I think Dr. Shruti wants to make a comment.
Just one line, sir.
Yes.
It is not that in all genetic myopathies riboflavin acts. This is not like a cocktail therapy that was given. There is science behind it. The gene that is mutated affects the flavinopathies, the precursors of riboflavin, and which is why giving this riboflavin corrects the metabolic pathway, and that is the same that applies for CoQ. I hope that we don't take a message that this is like a general cocktail that is given for all metabolic.
Yeah, very correct. Dr. Varsha, you want to tell about the availability of riboflavin and which preparations are there? Because a lot of people, the standard doses are so small, and these
Yes.
patients require more.
Typically in pediatrics, earlier we used to get those 10 milligram riboflavin tablets. And then if we had to give it to a child with a mitochondrial disorder or give a dose as high as this was a big task even for the parents. Luckily, sir, there are formulations which we can get through the Amazon. Like riboflavin is available more like a health and nutritional supplement through the Amazon. And there are a few brands now which have around 100 milligram of riboflavin along with another molecule. I wouldn't take any brand names, but it is available, which can be used, sir.
No, actually, pharmacology, even Indian pharmacopoeia approved 100 milligram riboflavin is also available, sir.
Correct.
Because we could find because most of the Madras motor neuron disease, all these things turned out to be riboflavin transporter deficiency.
Correct.
Later in life, we called back them and then looked at the genetic workup, and most of them turned out to be riboflavin transporter deficiency with bulbar dysfunction. At that time, we found out that there are a couple of brands available with 100 milligrams plain riboflavin tablets are available.
Correct. Absolutely. Now there is 100, 200, and 400.
400. All the
prices are and they are not expensive. So I think it's a good time for these patients. Yeah. Great. Thanks, Lakshmi.
Can I ask one question, sir?
Please, please. Yeah.
So can you tell me what are the essential differences between glutaric acidemia and glutaric aciduria? Second thing is glutaric acidemia 1 and versus 2. For the postgraduate.
I think the next presentation will cover this.
Okay. Thank you.
Yeah. They're very, very pertinent questions. Yeah. Thanks, Lakshmi, for asking them. So at this point, shall we now move to, you've seen one case. Now let's request Dr. Jarna to show you, to take you further. Yeah.
Yes, sir. How are you?
Good evening, everyone. Am I audible and are my slides visible well?
Yes, all good. All good. Yeah.
Okay, so I would like to start with a thank you for all the organizers to giving me this opportunity, and thank you, sir. So inherited inborn errors of metabolism, these are any condition in which the dysfunction of a biochemical pathway is fundamental to the disease pathophysiology. So as Madam Shruti ma'am said, that what is the science behind the treatment that we give? So I'm going to go into the details of that. So glutaric acidurias are autosomal recessive metabolic disorders. Lakshmi sir, to answer your question, glutaric aciduria 1 will be amino acid metabolism defect. So L-lysine, tryptophan, and hydroxylysine metabolism is affected because the GCDH gene mutation, dehydrogenase enzyme is affected, and that's why we get this glutaric aciduria 1. The glutaric aciduria 2 is also called as MADD, which is multiple acyl-CoA dehydrogenase deficiency. This basically affects the fatty acid oxidation with the mutation in the electron transfer factor or the dehydrogenase enzyme again. There is a mutation in that. So we'll go into the details of that. This is a very heavy flow chart, but if we go stepwise, we'll be able to decipher it. So fatty acids in the cytoplasm, they get converted into fatty acid acyl-CoA. Then with the help of carnitine, it enters the mitochondria. Now in the mitochondria, the acyl-carnitine goes through multiple steps to finally combine with the acetyl-CoA so that everything can enter the Krebs cycle. Now this requires a lot of enzymes, the main being the acyl-CoA dehydrogenase. Now to activate this acyl-CoA dehydrogenase, we need the FAD and we need the electron transfer factors, which is basically the ETC, electron transport chain in the mitochondria. So the ETFDH gene kind of codes these factors, the electron transfer factors, and hence they form they form this reaction of FAD to FADH2 and finally activate the acyl-CoA dehydrogenase. So if we don't have these particular genes, if there is a mutation in these particular genes, there will be no FAD formed and there will be no activation of the acyl-CoA dehydrogenase, and hence there will be increase in the acyl carnitine and there will be deposits of lipid accumulation in the tissue. So the clinical details, there are three distinct clinical phenotypes of glutaric aciduria 2, which are observed. The one is A type. Type 2A is neonatal onset form with congenital anomalies. Type 2B is neonatal onset form without congenital anomalies. And finally, type 2C is a late onset form, which Dr. Shamisha showed. So the neonatal form with congenital anomalies, these are usually seen with hypo or non-ketotic hypoglycemias, metabolic acidosis, sweat feet odor. I think Dr. Varsha and Shruti ma'am will be able to describe it better. And these patients have these dysmorphic features like high forehead, low set ears, hypertelorism, and hypoplastic midface. Along with that, there can be n number of congenital anomalies starting from cerebral dysgenesis, abnormal formation of bile ducts, GI tract abnormalities, kidney dysplasia. This can be seen in varied presentations. Coming to the late onset forms, the course and age of the onset is quite variable. The adult life can present, the patients in adult life can present with episodic vomiting, hypoglycemia, hepatomegaly, and proximal myopathy. So one point that we can take away from this particular presentation is late onset forms of glutaric aciduria type 2 mainly present with LMN symptoms. Proximal myopathy is the most common a phenotype that I found in the review of literature, which I'll be discussing further. So coming to the case, we saw a LMN case with proximal muscle weakness and fluctuations. So let's see what this chap has. 36-year-old male, started having symptoms in 2021, kind of had a subacute onset, proximal more than distal weakness, motor predominant, difficulty in walking, up squatting, same story. He also had a history of hepatic dysfunction in the past, which he just said lightly while he was narrating the history. Now, this time the CK was 4,500. The EMG was myopathic pattern. The histopathology was done, muscle biopsy was done, which showed patchy lymphocytic infiltration. And the diagnosis was rightly made, likely inflammatory myopathy. And the steroids were started. The additional finding this time again was there were some deranged LFTs, SGPT, SGOT was elevated. The outcome was a bit unusual. He had a gradual but near complete improvement with steroids within months. Now, after few months, he had a second episode. 3 to 4 months later of steroids, he had a similar proximal muscle weakness with no really exertional symptoms or any triggers. He had a similar proximal muscle weakness with a CK of this time 5,600. Again, he was treated with steroids and IVIG. This time, the recovery was a bit delayed, but again, he had a complete recovery. Now, the third time he came to us, he was completely wheelchair bound. And the MRC grading, in fact, this time the proximal was 2/5 in the upper limbs, and in the lower limbs also it was 2/5. We again rightly sent myositis panel and the other autoimmune features were negative. This time, this chap had no improvement with steroids or IVIG, and hence he was referred. The referring doctor, because he had no improvement with steroids or IVIG, he had done a genetic testing report and which showed a mutation of ETFDH, which we have discussed, with a likely compound heterozygous zygosity, with again inheritance of autosomal recessive. Now we again had this gene, but both of these were uncertain variants of uncertain significance. So to prove to give more evidence of this variant of uncertain significance, we did the carnitine acyl carnitine profile and the estimation of free fatty acids and beta hydroxybutyrate, which showed normal acyl carnitine profile which can happen in intercurrent illness. And there were low levels of free fatty acids or normal beta hydroxybutyrate. So the key clinical clue here is each time he improves completely. He returns to heavy workouts. In fact, the wife was saying that in between the two episodes, he actually returned to heavy workouts. But these heavy workouts didn't lead to any triggering proximal muscle weakness. We asked that, and he was pretty sure that they were not causing any triggered muscle weakness. This is quite unusual for an inflammatory myopathy, even when they are steroid responsive. So we made the diagnosis of late onset glutaric aciduria type 2. Now coming to the treatment of glutaric aciduria type 2 has two prongs. One is the maintenance treatment and one is the emergency treatment. Now these patients can have intercurrent emergencies triggered by some infection. So we have to have a sick day plan. If the symptoms get triggered by some infection, then what are the emergency treatment that we need to give? And then what is the maintenance treatment so that the patient doesn't get any triggered symptoms. So in the maintenance treatment, we have a low fat, low protein, high carbohydrate diet. Although the long-term treatment of late onset GA2 patient is still challenging, fat consumption should be restricted to 25% of the total calories. The main caution is the avoidance of fasting by not depending on beta oxidation for energy. The accumulation of toxic intermittent metabolites is avoided and the development of the most critical symptoms is also minimized. Now, in the emergency treatment, IV high dose of glucose 8 to 12 milligram per kg per minute to maintain the blood glucose more than 100 milligram per DL is the first treatment of choice. And then we have IV L-carnitine at 50 to 100 milligram per kg per day if there is a severe carnitine deficiency. Along with that, in maintenance, we give high dose of riboflavin, 100 milligram per kg per day. And along with that, we give L-carnitine, 3000 milligram per kg per day. So in the review of literature, we found these are the multiple papers that have been reported. One of them is in the Annals of Indian Academy of Neurology. And the maximum age being reported for late onset GA2 was 23 and 22. As we can see, the commoner features in GA2 is proximal muscle weakness, muscle pain, progressive proximal muscle weakness with dysphagia. So the takeaway point is this can be a huge mimicker of inflammatory myopathy as we saw here. So with this, I will go to GA1. Now GA1 is a defect in the amino acid metabolism. So protein in the food or the self-protein get converted to amino acids. Amino acids, particularly the lysine or hydroxylysine and tryptophan, they get converted to glutaryl-CoA. The final fate of this glutaryl-CoA is to get converted into acetyl-CoA so that this also can enter the Krebs cycle. Now, to do that, we need the enzyme glutaryl-CoA dehydrogenase. And this enzyme, when it is deficient because of the GCDH mutation, what happens is there is an accumulation of these back products, which is the glutaric acid, then the 3-hydroxyglutaric acid, and the C5DC with the combination with carnitine. So to come with the to understand the GA1 better, we'll see one case. So he is a 23-year-old guy with a normal antenatal history, normal birth and developmental history. At the age of 17 to 20 years, he had 2 episodes of unprovoked head injuries, after which these small subtle symptoms started with the onset of headaches, mild cognitive changes. There was this involuntary movements of the head, which the patient said that I am able to perceive, but no one else is able to see. There was also this posturing of the left hand while eating, and the referral diagnosis to us was seizures. For this, he basically sought a neurological opinion. And as we can see, this is the pedigree chart. He had a consanguineous, his parents had a consanguineous marriage, and there was a stillbirth in the second child, in his second sibling, and he had a focal dystonia. So he is a normal build, cognitively alert, activity induced, there was an activity induced left hand dystonia. As we can see, there are very mild tremors and focal dystonia on the left. He also had dysmetry and dysdiadochokinesis on the left side and a slightly abnormal tandem gait. The other systemic examination was normal. There was no hepato or splenomegaly. The records show normal CBC, LFT and RFT. The MRI of this particular patient showed a diffuse confluent and mild focal discrete T2 flare hyperintensities in the bilateral frontoparietal periventricular white matter with few small focal cysts, and the classical finding of glutaric aciduria, which is bilateral temporal arachnoid cyst, which gives the bat wing appearance. But here there were no striatal changes. This is important, which I'll explain in further slides. There are no striatal changes. So coming to the differential diagnosis, since glutaric aciduria is not that common diagnosis, it was not there in our differential diagnosis, to be frank. We were thinking of adult onset leukodystrophy with hyperkinetic movement disorder with evolving cerebellar signs. So the first one was adult onset metachromatic leukodystrophy, but there were no neuropsychiatric changes or peripheral neuropathy. And then there was the other differential, which we almost every time we keep this, which is the Wilson disease, but the MRI features were not really typical. So again, the genetic tests helped us in pursuing the diagnosis of glutaric aciduria. We got a mutation, homozygous, which was homozygous in zygosity in the GCDH gene. But again, this was variant of uncertain significance. To get more evidence on this, we did a biochemical test of gas chromatography and tandem mass spectroscopy. And we found that the glutaric acid in plasma was significantly raised. Another thing is the glutaric acid in urine was also significantly raised. And this is the back product that I spoke about in the previous flow chart, the C5DC, and the C5DC C2 ratio was significantly abnormal. So with this, a final diagnosis was late onset glutaric acidemia 1. Now coming to the clinical features, the clinical features may vary from macrocephaly, muscular hypotonia, movement disorder, orofacial dyskinesias, epilepsy, polyneuropathy, and chronic renal failure. But this has a this has a takeaway point that these symptoms may be seen at different stages of life. So as we can see, macrocephaly, muscular hypotonia, and movement disorder are quite predominant till the age of 6. And as we go beyond in adolescents and adults, we get to see a combination of a movement disorder with epilepsy or with polyneuropathy and chronic renal failure. So this is because the striatal damage and complex movement disorder with predominant dystonia and white matter changes is significantly seen in younger neonates, infants, and till the age of 6 years of age. And extrastriatal damage like polyneuropathy or renal disease can be seen in patients with GCDH mutation in the age group of adolescents and adults. Now coming again to the emergency treatment. The inpatient emergency treatment is again, we give glucose. And the natural protein should be stopped for 24, max 48 hours, and then reintroduce and increase stepwise until the amount of maintenance treatment plan is reached within 48 hours. If there is an infection which is triggering, if the body temperature rises more than 38.5, antipyretics such as ibuprofen or paracetamol should be administered. Carnitine has a role. IV carnitine, according to the normal daily dose, that is 100 milligram per kg per day, IV in infants should be administered. And coming to the maintenance treatment is a low lysine diet. Low lysine diet So in above 6 years, control protein intake using natural protein with a low lysine content and avoiding lysine-rich food. For example, I'll be discuss. I think Dr. Shruti might discuss this better. So, and again, we give carnitine 100 milligram per kg per day. Now, coming to the previously reported cases, adult onset glutaric aciduria type 1 presenting with a leukoencephalopathy was the first time when the adult onset GA1 was being described in 2002. Since then, there have been multiple case reports and studies. The maximum age that has been reported in the literature is 71. And this patient presented with dementia, tremor, epilepsy. And the other patient presented with seizures or stroke-like episodes and a cognitive decline. So the takeaway point from this particular case is there are heterogeneous presentation of GA1 in adults, late onset forms, which can range from headaches, nausea, vertigo, nystagmus dysarthria, hyper or hypoactive tendon reflexes, movement disorders, muscular weakness, transient ataxia, and fine motor deficits. So the key message is this is a diagnostic odyssey in adults. There is a need for awareness in metabolic experts, neurologists, and radiologists. We have to remember these are treatable inborn errors of metabolism, and hence we should suspect this more often. Awareness of role of metabolomics as the first tier workup in adult neurology, as well as an important tool in the case of uncertain genomics. Thank you. So I think I'll
Yeah,
hand
thank you.
over.
Thank you so much, Jarna. The cases were fabulous. I've
Thank you,
got
sir.
one little, when you become senior, there's one disadvantage that you have. That a patient comes to you, but before you can have a crack at the patient, someone makes the diagnosis. So in both these patients, before I could put my mind to this, Jarna has made this diagnosis in both of them. So it's actually fascinating and must congratulate Jarna. But sometimes I feel, why am I not the first one to take the history, do the examination, do the tests? Yeah. So with Lakshmi, Sudhir, and Dr. Manoj permission, can we extend the time a little bit more, or how are we?
Yes, sir, we can.
All
We can,
yours.
no?
Yeah, go ahead.
8 or 10 minutes more is
No
okay?
problem, sir. You can explain.
So I've got two questions here for the to sort of help the audience learn a little bit more. One is we will ask Dr. Varsha, who's done a fellowship in pediatric neurology, to tell us what's the pediatric perspective of these diseases. And then we'll go to Dr. Shruti Bajaj to ask her about this VUS. Tell us a little bit about VUS after Varsha tells about this and how, and what does one do when such a case comes? How does this VUS then become a pathogenic variant? What are the steps that you should take? So Varsha.
Thank you, sir. Thank you very much, Dr. Lakshmi sir and Sudhir sir, for giving me this opportunity. It's been a wonderful time, and we're seeing more and more interesting cases as they're coming by. I'm giving only the pediatric perspective. Is my slide audible? Am I audible and the slide visible?
Yeah. It's visible.
So half of my job is done because Jarna has given an extensive review of even the pediatric onset and what kind of presentations can be there. I'm going to just pick up a few things for us to take home from the whole talk that has happened so far. One, of course, it was described, the glutaric aciduria type 1 was described first in 1975. And they say that the overall prevalence is 1 in 100,000 newborns. In India, when I speak with Dr. Shruti and other pediatric geneticists and pediatric neurologists, unfortunately, we don't have a big registry. There are small groups which are working in different places, some collaborative works as well. But it is among the common inborn errors of metabolism, maybe amongst the first three, but we do not have the exact number. If I had to quote, they have grouped from 10 different institutions over 2 to 3 years, and there are papers with 30 cases, 45 cases. So we can understand with such a huge population, the number is small. If I look at it from the pediatric neurologist point of view, I'm looking at kids who have a sequel after an acute striatal injury. So these are normal kids having a illness, a febrile illness, and then regressing in their neurological symptoms and having a neuroregression. And usually the onset is usually between 2 to 18 months. The recovery from these acute episodes is usually slow and incomplete with some sequel because there is a striatal injury. So you may have a developmental delay, hypotonia, dystonia, dyskinesias, and varied form of movement disorders. So this was one paper that I picked up, Dr. Tamandkar et al., where they studied 30 cases. Now see, the mean age at onset was around 10 months, but the mean age at referral for the molecular diagnosis was over 2 years. So even if they are seen, by the time they're diagnosed, there is a lot of delay. And so this delay will eventually lead to fixed neurological deformities, fixed neurological sequelae, and lose the window of treatability in such children. These are those typical characteristic bat wing appearance. So the dictum is large heads, babies with what look like a subdural hygromas, and the temporal lobes, the fissures that are atrophied, give appearance of a bat wing. So that's the bat wing deformity. If we can see the fourth row from the left-hand side, we can see that striatal signal as well. So this may be the typical MRI findings. But interestingly, when I'm looking at the other cohorts from worldwide, there is a Turkish group where they've seen a 16-year-old with an inferior tonsillar herniation, a syrinx, which has developed over the years that come, and while the child from 16 went to up to 27 years of age. So we should not forget these kind of presentations also of these inherited metabolic disorders. Again, there is another one where we have the characteristic white matter changes for us to think of inherited leukodystrophy, but also they can cause a ventricular dilatation and require an endoscopic third ventriculostomy, which was very interesting that it came up in the literature. Now, so at the end of it, this was a very nice paper where they looked at glutaric acidureas from Karnataka, and they gave some very important key points. So for GA1, consider it if a child is a large head, there's an acute encephalopathy followed by a basal ganglia injury, white matter disease, movement disorders, subdural hematomas, subdural hygromas, retinal hemorrhage, and this isolated elevations of your glutaric acid, 3-hydroxyglutaric acid, and glutyryl carnitine in body fluids, especially your urine and your blood. So then are there studies where they looked at the prenatal diagnosis? So recently around 15 years data from Dr. Jayesh Sheth group came up where they checked around over 1,700 samples, and they found that inborn errors of metabolism was only 29%. But when they looked at the IEMs in them, there were only 11 cases. And from those, unfortunately, I couldn't find a GA in that group. But this is again biased. So these two slides are the take home for the talks, which I borrowed from Dr. Shruti. For the early onset GA, the onset could be as much as 6 years. For the late onset is after 6 years. And clinical features we know. What's important to know is that as it is a little older child or an older group, you may have wake symptoms, including headaches or just a large head. And you could have these characteristic neuroimaging findings. So the earlier the onset and delaying the diagnosis, obviously there's a poor prognosis. And because these children have typical crisis and they can go into sometimes even severe septicemia, and there can be a high mortality in these children. The later the onset, probably the neurological deficit isn't so much and the body has a time to accommodate. So there is a little better prognosis and a slower progression. So what's important is obviously the diet, red flags, which is the sick day plan, which Dr. Janna explained very beautifully. And early detection is the key because intervention is very crucial. We can probably help the siblings, help a family with a prenatal diagnosis and have a child who may be affected but have a normal lifespan and normal health. Going on to this glutaric aciduria type 2, if it is a neonatal onset with anomalies or without anomalies, they can have a severe hypoglycemia and a metabolic decompensation, and so can die in infancy even if you treat. So these are the very severe ones, even if they are type 2. And the late onset ones are usually, thankfully, the most common, but they have this characteristic muscle weakness, pain, and exercise intolerance. Thank you very much.
Thank you so much, Varsha, for the perspective. I think keeping the time in mind, let us now ask Dr. Shruti to tell us a little bit about the VUS and then a little about metabolomics.
Okay, sir. Yeah. I'll just, I think VOUS itself can be a 3-day CME, sir. I think in short, what we need to understand, there are various tools that we use as geneticists, right? From clinical correlation, parental testing, looking for biochemical markers, which is going to be my next 5 minutes of discussion, how these metabolomic testings come to rescue. So we understand it's the central dogma, right? DNA to RNA to protein, and then metabolites. So we cannot always rely only on DNA testing. Sometimes it's a surrogate rest of the pool that helps us to complete the picture, which happened in all the cases where it was uncertain, but we could help to reclassify it. All I would like to say is that as per the American guidelines, as well as geneticists, all our teachers, we always say don't act on a VOUS unless you have sufficient evidence. Prenatal, we have seen patients who have done prenatal testing on wrong VOUSs, terminated babies who didn't need to be terminated. So these are complex variants, parental segregation, biochemical testing, certain RNA-based studies. We do lots of various aspects to try to clarify the picture. And one of them, our hero, I think I always tell metabolomics is the new black. So we have to try and understand about them, get ourselves familiar with them. And I don't know if I can, 1 second, I'm so sorry. I think it's the wrong slide showing up. I will very quickly in the next 5 minutes take you all through metabolomics. And we've actually, Sir's team at Bombay Hospital, and we did a survey of 66 Indian adult neurologists. And I thought it's interesting to quote over here, 75% of them believed that the true incidence of IEM is only 2 to 3%, whereas adult onset IEM, the true incidence is 35 to 50%. And when obviously this study is under publication, not yet published. When we try to see what are they comfortable with through the questionnaire and what are they not, a lot of them were comfortable picking up the red flags and ordering the right test, but a huge proportion were not comfortable interpreting metabolic reports, genetic reports. They were not aware what is this ACMG classification, ordering second-tier testings, managing disease-specific emergency care, addressing multiple confusing genetic reports. And 20.3% of them believe that all uncertain variants are inactionable. So this is taking to where Sir's first question, that this is not the case. All uncertain. In fact, 80% of them get downgraded with time. It's 20 to 25% that get upgraded. For those of you who still feel our study is still ongoing, you can take a screenshot of this and please respond to our survey. It will just help us to strengthen the neuro genetic practice in India. I want to give one example which says that exome is not the frontier and also brings me to the topic of metabolomics. I know this is an adult neurology audience. I'll put it in short. This was who had all the clinical pathognomonic findings of a perinatal lethal Gaucher disease. We know Gaucher disease is a type of lysosomal storage disorder, but the exome was negative over here. But we had luckily, just before the baby expired, we had the opportunity of sending this child's beta glucocerebrosidase enzyme, which came out to be very low. So this diagnosis is enough. We have a diagnosis of PLGD, and based on this, we can even offer the couple amniotic fluid analysis of this enzyme. So this is the power of metabolomics, where we are all singing a lot of glory about genetics and exomes. We need to understand and bring to the forefront. This is no longer a supporting actor. It is very much a part of our clinical care. This was another example, which I think we can skip in the interest of time. So metabolomics is the study of small molecule metabolites. typically small molecules, but it could include any metabolites in biological sample. It reflects real-time biochemical activity. It's a functional readout of the genome in a way. So you're seeing what is a genome reading out for you. There are some targeted metabolomics which we are all aware of. So specific enzyme tests, ceruloplasmin, but then there are untargeted metabolites. So I don't know what I'm looking for, but I'm just ordering a TMS because I want to know the plasma amino acid profile and the acyl carnitine. There is urine GCMS, CSF metabolites, and very, very interesting is this broad untargeted metabolomics. It's like looking at metabolic signatures of various diseases like glioblastoma, tethered cord, Alzheimer's disease, early Parkinson disease, where just by looking at the blood and looking at the profile of certain proteins, there could be a prediction upon how and when would these disease manifest. So this is a bit futuristic, but I thought it would interest the audience. So this is, I think I won't repeat this. This was just to tell what are the types of the metabolomic findings that we expect in GA1 and GA2. I can vouch and tell honestly, none of us know these findings by heart. We also rely on our biochemical colleagues, our scientist friends, to, sometimes when we are not getting the report that we think is matching clinically, we go back, just the way a neurologist would have a back and forth talk with radiologist and electrophysiologist. So, we need to understand that these metabolomics not just help in diagnosis, they help in therapeutic monitoring. Both these individuals, when we had a follow-up, their built-up of the glutaric acid was down. To reply to your question, Lakshmi sir, glutaric acidemia is the accumulation of glutaric acid in blood, whereas glutaric acid urea is the accumulation in urine. They are both interchangeable because they're getting accumulated everywhere. And of course, with the help of metabolomics, if applied wisely, you can even help in reproductive decision making. I think I will just skip through this very quickly. So what are the red flags that should prompt you to think of neurometabolic disorders? If you have recurrent or reversible episodes which are triggered by fasting or certain elements in the diet, extreme illness, anesthesia, exertion, if you're seeing multi-system involvement, family history, multiple types of family history, but of course, even sudden deaths in encephalitis, some typical imaging findings, unexplained biochemical parameters. This is just, I'm going to take you through one or two examples. So for example, you have recurrent vomiting, confusion, stupor. A common misdiagnosis could be, is it just viral encephalitis or hepatic enceph? But well, a mimicking neurometabolic disorder could be urea cycle defects, and it can present even in adults. And these are the tests that you would do in them. So I'm just trying to show how there is no one size that fits all. Or tell me one metabolomic test. It's not like I order an exome every time. The metabolic test that I choose as a metabolic expert differs on the scenarios. Recurrent stroke-like scenarios could be MELAs in the hiding, and that's when you order some different test in the blood and the CSF. Likewise, it's a long list, but I know I don't want to delay the presentation further. So maybe just take one more example: seizures with hypoglycorrhea. We know autoimmune encephalitis could come this way, but it's a treatable GLUT1 deficiency, which can also come in a similar manner. And so multiple such examples are there. What we need to understand is that metabolomics need to be used as an adjunct, not as a lone diagnostic, along with clinical assessment, imaging, genetics, and try to start with targeted panels. So in both these cases, as Sir said, even I have a grievance, Sir, that these cases often come to us after the genetic test is solved. I said, where is the clinician in me going to be challenged? I wish you came to me without the genetic report, where I could have first ordered the TMS, GCMS, got the glee of seeing a high glutaric acid, and then ordered the genetics. So I think although there's a lot of difference in seniority, our grievances are same partly. So we have to start with targeted panels first, and then sample of choice, the test, the timing, everything is very important. For some tests, we tell the patient to fast. For some, we tell them to have a meal and get it tested. And of course, multidisciplinary care is important. There are challenges in analytical challenge, interpretations, clinical challenges, but I think we'll skip it in the interest of time. These are my references. And once again, a very, very humble request to all the esteemed neurologists here. We need your support to strengthen neurometabolic practice in India. And this survey can help us give answers and take us forward. And I'm very thankful to the team at Bombay Hospital. I'm the cat, probably among like the different person amongst all of you all. I'm not an adult neurologist. I'm a pediatrician trained to be a geneticist. My love for adult neurometabolism came through Professor Fanny Moschel during my course at Barcelona. And this is my team at the Purple Gene Clinic. I have to thank Niharika, my counselor, who made these slides for me at a very short notice because I'm actually out of town. So thank you so much. Thanks a lot. Thank you, sir.
Thank you so much, Shruti. I think we've seen various aspects of an unusual condition. And it's time for me to hand over the mic to Dr. Barucha for his comments and analysis. But before I do that, let me say this. There are people of various seniority in the audience. So let me say this, that to make a diagnosis of something like this, you need a team. You need people with different skill sets. You need people who can complement each other. Such diagnosis are possible only when you have a team of like-minded people. Like these 3 patients entered my consulting room, but unless there was a team working, it would not have been possible to make these diagnoses. So all of us need to build teams. It's not solo operation. We need to build teams. So with that, let me request Dr. Nadir Barucha, who is one of our most senior neurologists in the hospital and extremely interested in academic neurology, to make his comments, and then we'll hand it back to Dr. Lakshmi and Dr. Sudhir. Thank you very much. NEB, your comments, please. Yeah.
I see visible. I don't know.
Yeah, we can hear you and we can see you also.
Right. No, basically, Satish, I think I echo this point about the team totally. I mean, without this effort, and then I think if you have a top-down approach to neurology, it's never going to work. Where the senior sits on the top, the professor, and then assistant, and this and this and this. I think everybody the world is flat, as they say, and everyone has something to contribute. And also, it reminded me of Schoenberg's example when you talking epidemiology of blindfolded men feeling an elephant. Someone will feel a trunk and say, what is this? Someone will feel a leg, someone will feel a tail, a tusk, and no one, gets the full picture. Unless, you have different people looking at it, different specialties, and Shruti, I must commend you, it's superb. And Charna, to put it all together, but that really makes a difference. And you got practical, like Barsha, for example, and that you see these patients and you see them in the acute state. Very often, if they come to Satish and me, they come in the chronic state, and then we don't know, what the lactic acid is during the acute episode or what the glucose was at that time. So I think that's very good, very useful indeed. Thank you.
Thanks so much, NEB, first of all, for being there, for being always there on Saturdays with us. And you all have no idea how much she helps us. Thanks so much. Yeah. So I think before I hand over the mic to Sudhir and Lakshmi, I would like to thank both Sudhir and Lakshmi for doing this program and doing this for what, 6 years now? It's absolutely fabulous.
63rd episode, so
it's absolutely fabulous
3 months now.
What both of you do. So compliments on that. I would like to thank you for giving our hospital an opportunity to do this. And I would like to thank Cheda and Manoj. So Sudhir, all yours.
Should I say something, Lakshmi, or what you want to open? Lakshmi, shall I say something?
Please go ahead, sir.
So, first of all, congratulations for the fabulous cases and most wonderful analysis and a team approach that you have shown. And I think you have given perfect messages, and we are very thankful to you for all those things. Frankly speaking, while the case was being presented and the way things were demonstrated, episodes of fatigue and weakness, and then family history and some enzyme deficit, enzyme abnormality, transaminase, all that. So one of the differential diagnoses that was going through my mind was inborn error of metabolism or some kind of metabolic myopathies. And fortunately, the way you people have dissected out and the team has shown the perfect way how you handle such cases, I think it is amazing and so nice. I have one question, though I couldn't understand exactly how the how you explain the fatigability and also fluctuation, particularly in the sense she was demonstrating that after 4 or 5 rounds of raising hands, the person was feeling weak a little. And then she said that there was some difference between monsoon and winter. And so, I mean, what is the uh, metabolic fix of this thing? How does it really, you can exactly explain it?
Dr. Shruti, you want to take
Yeah.
it?
Yes, yes. So yeah, it's a very, very intricate observation actually. So glutaric aciduria type 2 primarily affects the mitochondria, as Jharna was showing in the pathway. And because of this stresses, the hydration level, fevers, mitochondria are very, very dynamic organelles. We know they are the energy, the banks of our cells which produce the energy. And so that is the reason why this pathway was and will always be under the influence of external factors which can precipitate it more. So better in monsoons than and worse in summers because summers are hotter. Depending if she's sweating more, these patients are also at risk of rhabdomyolysis. Individuals with glutaric aciduria type 2. So it is just simply that the whole heat factor with the exertion, with the relative cellular dehydration, was making the mitochondrial dysfunction come out more. I actually complimented her for her such a minute observation because what she said made entire sense. And the fatigability is because, and you won't see this fatigability in GA1, but GA2, because mitochondria is at the pivot of the pathophysiology, you may see this paroxysmal and fatigability and that kind of a clinical picture, sir.
Yeah.
I just
want to make one other comment that people who are weak, when they go on doing some activity, that activity also wanes a little. So one has to be a little careful about saying that it's fatigue and not just a manifestation of weakness. That's a practical point. Yeah.
Second point that I want to make is you're right. This neurogenetic business is really getting complex, and unless you have an astute person like Shruti, who very eloquently pointed out so many things and pitfalls as well as how to correct them, and coupled with high-level clinical examination as well as relevant blood tests, So this kind of combination is very vital in coming to the diagnosis or cracking the whole code. So I wish that many institutes in India would have the same kind of team that you have developed or you have, and sitting mentor like Dr. Bharusha at the top. So I think not only you are lucky, but you are a good leader that you have created such a wonderful team. And we also get really lost sometimes while reading the genetic reports, and sometimes we are misguided and carried away with some unknown territories. But unless somebody knows intricacies and does counseling, we can't be sure about the whole thing. So we really need classes, more classes on neurogenetics. With that, I would request, and I would present one of the days one interesting case of glutaric aciduria from our institute, but not this time. I'm not going to discuss this, but it's a very different kind of presentation, and that we have published also. So with this, I think Heli has done that with a colleague. With this, Dr. Lakshmi, would you please give final comments and wind up?
So my sincere thanks to the entire team for the real genetic piece which the Bombay Hospital gave. And as you rightly said, sir, in science, we all work together. Nobody works under anybody. So as you know, the team, everybody complementing each other is a very, very important, vital cog in the neurology nowadays. And secondly, the one more interesting thing is we keep blaming the seniors, blaming the younger generation. But I find the only thing is they are very, very fast. As senior people, we are so much of information on their fingertip. I find it very difficult to cope up with their swift actions on each case. So they come with a lot of information to ask you for a decision. I really find it very, very.
You went on mute, Lakshmi. You went on mute in between.
My hearty congratulations for the swiftness of this younger generation who have fingertip information with them. And
absolutely. They don't give you any time.
Time to think. That's sir, I am at least happy.
They finish it.
Sir, I am at least happy that there is somebody to share my. Sometimes the morning you say something and within half an hour they come back and say, "What is your decision, sir?"
Yeah.
We find it very difficult because we are a very slow generation when we grew up, and the information also for moving to the next step in neurology was so difficult those days. Nowadays, you know, the test with which the rapidity with which the tests are done, the information, the kind of enormous information which you have it in hand, and I think the hats off to the younger generation. They do a really good job. I'm really proud and jealous of them. And in fact, and I wish I'm born about at least 3 decades later. So I really congratulate the very young team of which you have built, sir. And we are, as Sudhir said, that your Professor Sudhir you are fortunate to have such a good team. And thanks for the wonderful presentation. And I'm sure that at least the postgraduates would have had a very good idea about the glutaric aciduria, acidemia, type 1, type 2, and what are the treatable in metabolic disorders, and what are the phenotypic clusters where you suspect. Thank you so much. And I think, is there anything else you want to add, Professor Sudhir?
No, just I wanted to say with names, Dr. Varsha, Dr. Jaranan, Dr. Shruti must be complimented heavily.
Yes,
along with the senior resident who presented the case very eloquently. So once again, we are very, very thankful to the Bombay Hospital team and Dr. Satish, my personal friend. I feel so happy that he was my contemporary. We studied together and look the height that he has reached and taught so many students. So thank you once again. And Dr. Barucha was my mentor. He was my teacher.
Over to Mr. Arun Chadha.
Thank you, sir. As we conclude this evening, highly insightful 63rd episode of Secret of Neurology, I, Arun Chadha, Senior Vice President of Intas Pharmaceutical, once again offer our most profound thanks to our incredible course director, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir. Your vision in designing this unparallelable, that is a web series, has created a truly invaluable resources for every DM and DNB students. We are incredibly grateful to the young neurologist, Dr. Samisha, for sharing their insightful case presentation. And we are thankful to all our distinguished presenter and discussant, Dr. Jharna Mahajan, Dr. Varsha Patel, Dr. Shruti Bajaj, for localization this case and giving their insightful, especially in the gene studies are there. And we are thankful to Dr. Nadir Brucha sir for decoding the disease spectrum, and really their presence in this series that is really recommendable and remarkable, sir. Thank you, Brucha sir. And we are very thankful to our esteemed summarizer, Dr. Satish Khadelkar sir, Dean, Bombay Hospital. Your expertise and dedications are the very heartbeat of this program, sir. And finally, to all our esteemed delegates, thank you. Your constant and gracious presence over the past 63 months has transformed this series into a vibrant national forum for the neurological learning. It has been a true pleasure being with you. We eagerly look forward to you on welcoming you back for the
Official.
next highly anticipated session of Secret of Neurology on November 29th. Until then, stay safe and continue your great work and take care. Thank you. Thank you, sir. Thank you very much.
so much.
Thank you.
Good
Thank
night.
you. Thank you so much.
Thank you.
Good night,
Thank you.
everyone.
Thank you, sir.
Good night, everyone.
Good night. Good night. Good night, sir. Good night.
Namaste, Dr. Barucha, sir, please. Thank you.
Thank you,
Thank
sir.
you, huh? Thank you for involving me.